morning, everyone. Welcome to tonight's webinar. My name is Dan Green. I will be your host this evening. Tonight is Tuesday, November 22nd, 2022. As it's a Tuesday, we will be doing cases from volunteers' case list. So I will ask for volunteers, if you've been in the hot seat, let's say Sunday or Monday of this week, if you could, excuse me, give your colleagues a chance to have a turn in the hot seat, that would be appreciated. But if we don't get enough volunteers, happy to take folks even that have been in more recently. A couple quick announcements. So we will stop roughly around 9:20, so we have 10 minutes to go over any questions, although we will go over the cases after. And I do want to remind folks, if anyone is interested in taking the quote-unquote Dallas finishing touches course, I will tell some of the days are looking up already, so you may want to reach out to Karina or Beth. Again, if you have any interest in that. That's a half-hour mock oral as well as a 1-hour lecture. The lecture is, first part is a review of techniques and kind of a pep talk, what to expect, and the second part is a review of recent changes in the standard of care, as well as 1 or 2 maintenance certification articles, just so you're an idea of kind of stuff that your examiner may have been reading. Okay, having said all that, we will now get started. So, Christine, try to take you off mute.
Hi.
Hey, how are you?
I'm good. How are you?
Good. Refresh my memory. Are you a generalist or specialist?
I am a GYN oncologist.
Aha. Well, guess what we won't be asking you?
GYN?
No, but we will be bothering you the rest of the night for other questions. All right. So since I don't see an OB list for you, we will go with your office list.
Okay.
So I see that patient number, let me actually show this to folks, sorry about that. I see that patient number 11 had a history of stage 3B cervical cancer, and she received Gardasil. So tell me, what are contraindications to the HPV vaccine?
So contraindications for the HPV vaccine would include an allergy to any of its components. It would include pregnancy. Currently, it's not recommended for anyone over the age of 45.
Okay, you said allergy to any one of its components. Do you know what components are in it that someone might be allergic to?
I will have to refresh on that, but I believe there might be I can't remember if that one has an egg allergy or not to it. I don't think it does.
Okay. So she's 39. What other vaccinations would you check on for this patient?
So for someone who is 39, I would check to see that she's had an MMR. I would check to see when her last Tdap was. And if she had not received, if she'd only had the tetanus, diphtheria, I'd make sure that she had had a Tdap at some point. I would screen her for other comorbidities such as asthma. That would put her to qualify for the pneumococcal vaccine early. I would make sure that she's had the hepatitis B series. I would make sure that she gets the annual influenza vaccination, as well as check her COVID-19 vaccination status.
Okay. So regarding the tetanus, how often does a patient need a tetanus shot?
The TDA shot is given every 10 years.
And again, if the patient has an at-risk injury, how often or how soon would she need a booster?
If she's had an at-risk injury, she needs a booster within the last 3 years.
Okay. Now, you mentioned early pneumococcal, so you said asthma. Anything else that you can think of that would require? Go ahead.
So any sort of pulmonary conditions such as COPD or with bronchiectasis or any immunocompromised state?
Okay. Otherwise, when would a patient normally get pneumococcal?
Pneumococcal is recommended at age 65.
I'm sorry, one more time?
65?
65?
Mm-hmm.
Okay. And you mentioned MMR. How long would you advise her to refrain from trying to get pregnant if she got the MMR vaccination?
So if she had the MMR vaccination, I would recommend that she abstain 3 months prior to pregnancy.
And what if she got pregnant, let's say 3 weeks later after she got the shot?
So if she did have a pregnancy, I would probably get an early first trimester ultrasound. I would recommend that she have an appointment with maternal fetal medicine. And during her second trimester, I would recommend that she had a full anatomy scan with full anatomy scan.
What about varicella? How long would you wait? How long does a patient need to wait after varicella?
So varicella is also another live vaccine. So I would also recommend to wait 3 months prior to pregnancy.
Okay, same scenario. So if she gets pregnant soon after, would you do the same thing?
Yes.
Would you counsel the patient regarding termination?
I mean, I think termination is always an option for any patient. So, I think regardless.
No, I mean because of this.
But I was trying to find a sly way out of it. I would counsel her. I believe for the rubella, but I don't believe so for the varicella. And I'm not sure why, but I believe that's the correct answer.
So you would, now again, would you recommend the patient consider, is that what you're saying? You'd recommend she consider termination?
I would just offer it.
Okay. Okay, so let me see here. All right, let's stop here and go over it.
I never would have thought any of those questions.
I'm sorry?
I never would have thought of any of those questions. Thank you.
Oh, not at all. Actually, something just came out in October regarding vaccinations too, and ACOG is very big on pushing us for vaccines. A few years ago, there was a bulletin or committee opinion that came out that suggested that we hire a vaccination nurse, that someone in our office to track vaccinations. It's like, are you kidding me? I'm sure we can all afford to hire a person separately just to track vaccinations. I mean, but having said that, again, it's a big deal. So do like to make sure you guys go into the test knowing the vaccinations just in case. Excuse me. All right, so HPV vaccine. So contraindications, pregnancy, you mentioned over 45, sure. You said egg allergy. So in the quadrivalent vaccine, egg allergy was a contraindication, but in the nanovalent, it's actually a yeast allergy that would be a problem. So we have pregnancy, yeast allergy, and also a patient that has a history of Guillain-Barré in the past would be contraindicated. In terms of your vaccinations for the 39-year-old in general, you mentioned flu and COVID, so good job there. You mentioned tetanus every 10 years, and again, at least one Tdap as an adult. If she has an at-risk injury, you said 3 years. The reality is if someone shows up with an at-risk injury, like to the ER, to patient first or whatever, they're always going to vaccinate a booster. But technically speaking, if it's documented that the patient has had a booster within the past 5 years, she does not need to be revaccinated for the at-risk injury. So early pneumococcal, you were correct about your 65-year-old. So patients that have a chronic condition, somebody who's had cancer could be a patient that's a candidate for an earlier pneumococcal. Splenectomy, you said immunocompromised, specifically splenectomy would be another. And somebody that has severe pulmonary conditions, you certainly could consider giving the DEXA earlier. Hepatitis B, yes, they want everybody to be vaccinated against hepatitis B. So your varicella and MMR. So the time period to wait is 1 month after the last dose of the vaccine. And if they get pregnant, you'd want to inform the patient that it's a theoretical risk. There's never been shown to be a case of congenital rubella or varicella because someone received a vaccine too close to when she actually got pregnant. So again, we wouldn't give it in pregnancy, but if somebody conceives 2 to 3 weeks after, again, we wouldn't recommend any changes. Let's see if there's anything else. Do you have any questions for me, Christine?
No, that was great. I would never have thought of going down the pregnancy route with like going through the vaccine. So that was very helpful.
Well, I'm glad you found it, so thank you for volunteering. Appreciate it.
Thank you.
Okay, thank you. Melissa, trying to take you off mute next.
Hi, how are you?
Good, how are you?
Doing well, thanks. Actually, before we start, could I ask a question about that last case?
You sure can.
Thanks. For the patients who qualify for an early pneumococcal vaccine, do you give it sort of like at the time of diagnosis of their chronic issue, or is it like earlier, meaning, in your 50s rather than 65?
Yeah, so no, it's usually given at the time of diagnosis of the problem. So if someone has a splenectomy, obviously you're going to wait till she's post-op, but yes, you would give her the pneumococcal earlier. When I say earlier, again, I mean at the time. Someone is diagnosed with cancer or some other significant chronic disease. I'm not talking about a patient who's hypertensive, obviously, but somebody who's got a serious medical condition. Certainly autoimmune diseases, potentially, especially if they're going to be on steroids and what have you. These would be people that you would consider earlier, but again, meaning at the time of diagnosis, not in the 50s.
Got it. Thank you.
Sure. Are you a generalist or specialist?
I'm a fellow in complex family planning.
Complex family planning. Okay. Let's see what we got here. All right.
Great.
Okay. Sorry, one more time.
Oh, if we could do OB, that would be lovely.
Okay. You saved yourself from GYN, which is where we were headed.
Oh.
It's all good. Give me a second here and we will find somebody for you. All right, so patient number 4 is 39-year-old, at 22 and a half weeks. with a short cervix and a history of a prior preterm birth. So she had a McDonald's cerclage placed. So what are your criteria for cerclage?
So my criteria would be I would be thinking about a history indicated cerclage, meaning that someone had a prior preterm delivery in the absence of infection, of course not an iatrogenic or medically indicated delivery, and you could do that sort of prophylactically in the early second trimester. You could have
sorry, Melissa, say it one more time. They had a history of what?
A history of a prior preterm delivery. Now I'm doubting
before
myself.
What gestation?
Certainly before 34 weeks.
So if somebody has a history of a preterm delivery before 34 weeks, that would be criteria for history indicated cerclage?
It would have to be a delivery in the absence of a PPROM or infection, and of course not a medically induced delivery. I'm doubting myself now, but I would, I'll come back to that. Another indication for cerclage that I would think of would be an ultrasound indicated cerclage, where someone with, again, a history of a prior preterm delivery has a cervical length of less than 25. And then finally, the third indication would be a physical exam indicated cerclage.
Okay, so you mentioned for the sonogram indicated, you said preterm delivery with a cervical and now has a cervical length less than 25. I assume you mean millimeters on the 25, but preterm delivery before what gestation?
I believe the criteria for that preterm delivery are the same for the history indicated as well as the ultrasound indicated. And
well, so I guess I'm a little puzzled. So if someone has a sonogram, what you just told me, history of preterm delivery less than 34 weeks, obviously not being induced for preeclampsia or something like that, and then the history indicated is history of prior preterm delivery before 34 weeks. I mean, if you're saying one patient's less than 34 weeks, we're going to do we're going to offer her cerclage because of the history indicated, and we're saying the next patient by ultrasound needs to have the same delivery before 34 weeks, but she, on the other hand, has to also have a cervical length of less than 25 millimeters. That kind of doesn't make sense.
Right.
Why are we holding the sonogram person to higher standard?
Right. Yeah, I mean, obviously I would have to review this, but now that I think about it, I believe that for the ultrasound indicated, that could also include particularly second trimester deliveries or, spontaneous abortions.
For ultrasound indicated.
I believe so.
Okay. So what are your criteria for recommending a patient be offered vaginal progesterone?
So if a patient has a prior, I'll start with, if a patient is nulliparous and is found to have a cervical length less than 20 millimeters, and I'm sorry, rather than nulliparous, I mean to say that they've not had a prior preterm delivery, and then they have this cervical length of less than 20 millimeters, you can offer them vaginal progesterone. And in addition, I think that if someone has a history of a preterm delivery less than 34 weeks, you can offer them progesterone either in the form of an IM injection or vaginally.
Okay, before 34 weeks. Okay, let's say you had a patient who is nulliparous, so a G1P0, who is getting her anatomy scan roughly at 19 or 20 weeks. And the radiologist calls you up and says, hey, doc, I just scanned your patient and everything looks good. I didn't see anything anatomically incorrect, except I noticed that the length of her cervix was 9 millimeters. What would you do with that patient?
I would, this would be a patient who I believe would qualify for vaginal progesterone, but I would also, counsel the patient about the findings, and I would consider doing a cervical exam.
Okay, so you do a cervical exam and you do feel the cervix is shortened. Would you do anything differently now?
I don't believe I would intervene unless I felt that the cervix was dilating.
Okay. Are there different types of vaginal cerclage?
Yes, there is a McDonald cerclage. Well, I suppose you said vaginal, but there's the other type of cerclage is Sherrodcar, which is performed abdominally.
A Sherrodcar is performed abdominally, sorry. Is that what you said?
It is what I said. I haven't performed these or seen one before, but I understand that it can be performed abdominally.
Okay. So when would someone do an abdominal cerclage?
If a patient had a prior history of a failed McDonald cerclage, or if there were perhaps a structural issue preventing a McDonald cerclage from being performed. For example, if a patient had multiple leaps and had a cervix that was, flush with the vagina.
Okay. All right, I think we will stop here so we can go over it. All right, so cerclage. So there are 3 indications for cerclage. There's a history indicated cerclage, as you mentioned, an ultrasound indicated, and a physical exam indicated. So a physical exam indicated would be what we would consider like a rescue cerclage. So a patient comes in, usually it's in the mid to late second trimester. She's found to be dilated and perhaps effaced without evidence of, painful contractions or preterm labor. That would be a patient who would be a candidate for a rescue cerclage or physical exam indicated cerclage. So the history indicated cerclage would be actually a patient who has evidence of cervical insufficiency based on her history from a prior pregnancy. So she came in, she reports a history of a second trimester loss. Usually doesn't have to be, but usually 20, 22 weeks, that is preceded by painless dilatation. So she shows up in the labor and delivery saying, I have to feel a little pressure. You do your speculum exam, you see bulging membranes or what have you, and where she's fully dilated, and she proceeds to miscarry. So that would be one of the parts for a history indicated cerclage. The other way that someone would qualify is someone who had a cerclage in a prior pregnancy for an appropriately indicated reason. So for whatever reason, she had an ultrasound placed, but it was legitimate. It wasn't like somebody going, oh, well, you delivered at 36 and 6 days. I think we'll put a cerclage in you this time. No, obviously not something goofy like that. Ultrasound indicated cerclage would be somebody who delivers before 34 weeks, again, non-iatrogenic, so not for like preeclampsia or fetal growth restriction. She delivers before 34 weeks, and we would do serial cervical length monitoring for her. So we would do cervical length starting at 16 weeks through 24 weeks, and we would get them every 2 weeks. And if we found her cervix to be less than 25 millimeters, she would be offered a cerclage. So those are the indications for cerclage. Now, vaginal progesterone, you said no history of preterm delivery or what have you, but incidentally found cervical length less than 20 millimeters. So that's the way it used to be, but now it's actually 25 millimeters that they recommend. So again, patient without any prior history but has a cervical length incidentally found to be 25 millimeters or less could be offered a cerclage. Could be offered vaginal progesterone. If someone has a history of a preterm delivery, you said less than 34 weeks, you could offer IM or vaginal progesterone. So actually, that would be anybody that delivers preterm. So it's not really 34 weeks, it's really up to 36 and 6. And then I threw out one at you. I said, patient kind of incidentally found to have a 9 millimeter cervix, and has no history of cervical insufficiency or preterm delivery. What would you do? And you mentioned vaginal progesterone, which isn't wrong exactly, but anybody that is incidentally found to have a cervical length in the second trimester of 10 millimeters or less would be recommended to be offered a cerclage. So certainly you could give her vaginal progesterone and place a cerclage, offer a cerclage, but that would be another reason to offer cerclage. In terms of types of cerclage, you mentioned a McDonald and a Sherrod-Carr. So those are two types of vaginal cerclage, or at least they're placed through the vaginal route. A McDonald is a purse string suture and is the easiest to perform. A Sherrod-Carr involves dissection of and pushing the bladder up in a cephalad fashion and the rectum posteriorly. Again, pushing that toward in a cephalad fashion. Basically, what you're trying to do is you're trying to get to the level of the internal os, and you're trying to place your suture there. So you're going a little higher. You'd basically tunnel your stitch through the cervix. So you go in at like 12 and come out at 6 with a Merceline tape. Go back in at 6 and come out at 12. You tie the knot, and then you'd reapproximate the tissue that you dissected. You'd place that over and basically burying the stitch. So these used to be thought to be more efficacious, but that's not been shown to be the case. So the only time someone would do a Sherrod-Carr as compared to a McDonald would be if there's not enough cervical length to actually place a McDonald. And then for abdominal cerclage, which I think you may have mixed up a little bit with the Sherrod-Carr, you mentioned failed McDonald. So that's kind of correct. It's failed vaginal cerclage would be an indication for an abdominal cerclage. And then you mentioned or described what is almost like a trachelectomy. So either too much cervical shortening or absence of the cervix by virtue perhaps of a real trachelectomy would be another indication for an abdominal cerclage. And I didn't ask you this one, Melissa, but when would you take out an abdominal cerclage?
After someone's completed childbearing?
Okay, so you certainly could do it at the time of the last C-section if you're tying the patient's tubes, because you'd want to be absolutely certain she's not having any more kids. And how she could be certain is if she's having her tubes tied, or obviously if you're doing a hysterectomy, or you can just leave it in place. So there's kind of three options there. Any questions?
Yes. For a physical exam indicated cerclage, is it? You mentioned that they should be like dilated or effaced. Is there like a sort of hard cutoff as far as like how effaced or how dilated?
Yeah, so it's dilation usually with effacement. I don't know of an absolute number, and I've looked it over and haven't found anything. I would hazard an educated guess to be about 2 centimeters. I don't know that that's a hard, fast number. Certainly, if we have any MFMs on there, please feel free to type in the question box an answer, or you can wait till 9:20 and we'll take hands and be happy to know that, because I haven't been able to find an absolute. It wouldn't be like somebody who's fingertip, that's for sure, but Again, I'm thinking it's 1 to 2 centimeters, but that's an educated guess, not an absolute.
I see. All right. Thank you very much.
My pleasure. Thank you. Okay. Alex, I see you're volunteering.
Yes, I am. Can you hear me?
I can. Are you a generalist or specialist?
I am a generalist.
If you've been an MFM, we were going to put you on the spot for that last question.
Well, luckily I'm not. So.
All right, give me 1 second. Let me pull up your list. Okay, so let's see what we got here. So patient number 3 is a 42-year-old G3P3 with recurrent cervical dysplasia, CIN3. She had a leap with negative margins, dysmenorrhea. She's a smoker, and the ultrasound was unremarkable. You did an LAVH salpingectomy with a peritoneal biopsy. Cervix showed CIN3 with negative margins, adenomyosis, fibroid, fallopian tubes were benign. She did have some endometriosis. So what was the main indication for this hysterectomy?
For this patient, she had been struggling for a long time with dysmenorrhea and had been referred to me for treatment after she had failed routine OCPs and NSAIDs. So I discussed with her dysmenorrhea, and then I did note that she had the CIN3 on her pap smear, and so she was really strongly leaning toward wanting a hysterectomy. I did discuss with her that she had the leap in the past with the negative margins, but the CIN3 had recurred. So I thought that it would be appropriate to do the hysterectomy.
I'm sorry, let me interrupt for just a second, Alex. Yeah. So I guess I'm not 100% following you with the with respect to the dysplasia. So you have recurrent CIN3, so that was like right now she had CIN3?
Correct.
Okay, so in the past she had some sort of dysplasia, had a leap.
Yes.
The leap cleared the dysplasia because she had negative margins. Is that right?
Correct, yes.
Okay. And now she had CIN3 as diagnosed by, I'm assuming, an abnormal pap and then subsequent colposcopy?
Correct. I did a colposcopy on her the first time I met her as well. And she had this, yeah.
Okay, so she's got an active diagnosis, if you will, of CIN3, right?
Mm-hmm. Yes.
So how come, did you do any kind of excisional procedure before you took her for this LAVH?
I knew you were going to ask that, and the answer is no, I did not.
How come?
Sorry, I just tested myself for COVID. It was negative, but I sound like a teenage boy, so I apologize. I did not test her because when I was looking at her cervix, she was she'd had 3 prior vaginal deliveries, and the way her cervix looked and was shaped, it was somewhat, not completely flush with the vaginal posterior wall, but I felt like if I did another leap, I didn't feel like I would be able to get an adequate sample. So I did go ahead and do the hysterectomy after discussing it with my oncologists who were around at the time that I did this hysterectomy.
Well, so let me ask you a question. I mean, could you have done a cold knife cone?
Yes, I could have, but she did want treatment for she was having the severe dysmenorrhea as well.
I get it, but I mean, how did you know she didn't have cancer when you did this hysterectomy?
I was not completely sure at the time.
So, I mean, what would have happened if she did have invasive cancer?
If she had invasive cancer, I would have had to send her to so like I said, I did have the gyn oncology on standby in case we got in there and it looked abnormal, but I did not perform a lymph node dissection at the time. So she would have had to been sent to gyne-oncology for possible lymph node dissection depending on the stage of the cervical cancer.
How is cervical cancer staged, clinically or surgically?
Surgically.
Are you sure?
No.
Okay. If you knew somebody had, let's say you knew she had an invasive squamous cell carcinoma, what surgery should she have?
If she had an invasive squamous cell carcinoma, she would need a radical hysterectomy.
So what's the difference between a simple hysterectomy and a radical hysterectomy?
The radical hysterectomy takes the top portion of the vagina and perimetrium, and also the uterus, tubes, ovaries, and then also removes, I believe, a portion of the peritoneal wall from the abdomen as well. And if I'm correct, I believe it takes a small portion of the bladder even.
So, I mean, you know, you said you had oncology on standby, but I mean, standby for what? Did you didn't send it for frozen? I mean, and if you did, what would they do differently? Can you take the perimetrium after you've done the hysterectomy?
That I'm not sure. That I would have had to refer to them to ask about.
If she were only agreeing to one procedure, so to speak, I mean, could you have done, or one anesthesia? Is there something you could have done that would have satisfied you and her?
If she was only agreeing to one procedure,
Well, one anesthesia.
one
In
anesthesia.
other words, right.
Well, right. If that was the case, then I would have probably sent her to gyne-oncology to do the procedure, the entire thing, and send it for frozen.
Okay, again, once you've taken out the uterus, you kind of missed your opportunity for the perimetria.
Okay.
But we'll defer to Christine in a minute. Okay. Did she have a known history of endometriosis?
It hadn't been surgically diagnosed, but she had symptoms that were consistent with endometriosis and had been long-standing.
What are some of the theories of spread of endometriosis?
The main theory, or the leading theory, would be retrograde menstruation, where the endometrial cells travel outside via the fallopian tubes and implant on the peritoneum or the bladder wall or anywhere in the pelvis. I know that there are 3 theories. That's the one I'm most familiar with, and I'm kind of blanking on the other 2 right now.
Okay. So, what was the other thing I was going to ask you? All right, I think we will stop here. So here's the issue with this patient. So, I mean, you know, given that she had active cervical dysplasia at this point, I mean, that's what your colpo showed, but we don't know that for a fact that she didn't have, you know, invasive cancer. So this is always kind of the discussion, you know, should you do another excisional procedure to make sure, you know, to basically have, and you need negative margins with it. Then some people say, well, if she had negative margins, why would you even offer the hysterectomy? Well, it's reasonable to offer a hysterectomy because she is at increased risk for recurrence of the CIN3. So, you know, once she's had CIN3, again, that part's fine. And again, the dysmenorrhea certainly just adds, you know, an extra reason. But the concern is, you know, again, how did you know she didn't have invasive cancer? And cervical cancer is staged clinically.
Okay.
But you know, if she had invasive cancer, you would want to do or oncology would want to do a rad his on her
Right.
which would involve taking the parametrial tissue in the top of the vagina,
Okay.
as well as the tubes, ovaries, etc., and lymph nodes, but potentially. But if if you take out the uterus and send it for frozen, they say, oh, she's got invasive cancer. Again, really can't go back and take out the parametrium at that point.
Okay.
So that's kind of the thing. What I was getting at is when I asked, is there something you could do to kind of split the difference with the patient? If she had enough tissue to do a cone, and again, you can control things a little bit better sometimes because you have the knife. It might be a jagged cone, but it might be a cone all the same. You could do a frozen cone. So in other words, put her to sleep, do the frozen cone, comes back, CIN3, but margin's negative, then you just proceed with the hysterectomy.
Okay.
And the only caveat would be, hey, if it comes back showing invasive cancer, which again we're not expecting, but if you have oncology there, then they could come in and do the rad hist. But if not, obviously you'd wake her up, but then she'd still have the proper procedure.
Okay. So do you have any tips on how I can defend this or change my wording at all to make it sound better?
Yeah, I'll give it to you in just a second. The only other thing I would say is, it's a theoretical thing. I mean, gosh, we've been talking about this since I was a resident, so for a good long time. Even though different management's changed a little bit, but I will tell you, it was either this year or last year I saw my first case of someone actually, doing. Don't take this this isn't intended in a mean way, but doing what you did, and the pathology came back invasive cancer.
Oh gosh.
Yeah, and it's on their list.
Oh boy.
So anyway, I've never seen it before, either in practice personally or whatever, but it does happen, albeit rarely. So I think what I would say here is, the patient did have, active disease. As you initially told me, when I assessed the patient's pelvic exam and cervix, there were parts of the cervix that were flush with the vaginal apex, or the vagina rather. And I was concerned that I just didn't have enough room to actually safely do another excisional procedure. I explained to the patient that there was a chance that she could have invasive cancer, and but at the same time, an oncologist is not going to do a rad hist on she might have invasive cancer when all we see is CIN3.
Right.
So, and again, I'm not suggesting to be dishonest, but I think that's what you told me, isn't it?
Yeah. And it just didn't sound as concise.
Yeah. I've done this once or twice, so practice makes perfect.
Okay.
But interesting case, a little tricky. It is kind of toward the front of your list, so certainly could come up.
Yeah.
Any other questions?
No, I don't think so. Thank you so much. I appreciate it.
My pleasure. So, Christine, I'm going to put you on the spot, trying to unmute you if you don't mind unmuting yourself. There you go. Do you have any comments or suggestions or anything based on this last case?
I have had a patient come in similar scenario where I guess I would stress a shared decision making, that the patient understood there could be a risk of cancer. I have had one actually like a month ago that had a vaginal hysterectomy and had a 4-centimeter tumor.
Ooh.
In terms of management, a radical perimetrectomy can be performed with an upper vaginectomy, but it's very rare. Most people don't do it. In general, with cervical cancer, especially early stage, things have sort of been changing with the LAC trial that came out a few years ago, which found an increased risk of recurrence with people who had radical hysterectomies performed minimally invasively. So even the route of doing a radical has dramatically changed. So, I mean, that's the only, I guess, 2 cents.
A question: Are they doing Are you saying they're not doing parametrectomies, period, anymore?
They're not doing, no, I'm saying radical parametrectomies where you've had the uterus removed already. If
Going back.
Yeah, I would say it's rare that someone will go back and do a radical parametrectomy with a lymphadenectomy and upper vaginectomy. Normally, they'll get a PET scan and then determine if they have to do any nodes or if they would just go to chemoradiation based on the size and stage of it.
Would you mind going through, the parts of a radical hysterectomy?
Sure. So if you're doing a radical hysterectomy, most likely it would be open because, like I said, it's basically recommended to be open for any early stage cervical cancer except for a 1A1 without LVSI, because that would be a simple hysterectomy. So when you're doing a radical hysterectomy, what you want to do is you want to get a 2-centimeter margin below the cervix. You're taking the upper 2 centimeters of the vagina. So when you're dissecting down, you want to make sure you have that good margin. If you're doing a modified radical, it means that when you're finding out where the ureter is, you're completely tracing the ureter, and then you're going to tunnel the ureter underneath the uterine artery, and you're going to take the uterine artery basically at the tunnel and roll your ureter laterally to take that parametrium between where the uterine artery crosses over the ureter and everything that's medial to it, to the uterus. And then when you're doing your uterosacral ligaments, so you'll want to dissect down in the pararectal space to see your RV septum, and you want to go down and get about 1 centimeter or 2 of the uterosacral ligament. If you're doing a full radical, you're taking your uterosacral ligaments, you're trying to get as far down as possible to the point of origin. You're going to not roll your ureter laterally, but you're actually going to get even more parametrium. So you're going to dissect out the entire ureter. And again, you'll get that 2-centimeter margin on the vagina. The biggest thing with those, if you're doing a full radical, is that you can damage the hypogastric plexus, which is the innervation for the bladder. So you can have certainly bladder complications in terms of emptying after that. I don't know if that helps.
Thank you.
Yeah, it does. Thank you so much.
More than we non-oncologists ever wanted to know about rad hysts. But yeah, I've honestly never seen, read about, or even heard of the post-hysterectomy parametrectomy. It just seems like it'd be really tough. But
read it.
Thank you. Sorry?
I've read about it. I've never seen it or done it.
Okay. So yeah, so that's that's kind of the rationale, Alex, in terms of wanting to prove the negative margins before proceeding. And thank you, Christine, for being letting us call on you for your expertise. Okay, so let's see who's next. Sorry. Lauren, are you volunteering?
Yeah, I can volunteer.
I saw your hand up, so I just.
Yeah.
Are you a journalist or?
I'm a G1 oncology fellow.
Another oncologist.
Yeah.
Wow. we could have picked on you some then too. Mm-hmm. All right, let's see here. Just opening your list up. I'll be a minute. Okay. So patient number 6 is a 39-year-old G1P0 at 39 and 3 days.
Sure.
A category 2 fetal heart tracing. She's AMA, fetal bradycardia, and she had an emergent primary C-section with 8 and 9 APGARs.
Sure.
So tell me, doctor, when you have a patient that she's 39, let's say she was 41. When you have a patient who comes to you who's pregnant and she's 41 years old, how does that affect your antepartum care and let's say peripartum and peripartum care?
So At 41, after 35, the patient is considered advanced maternal age with an anticipated delivery greater than 35 years old. And I would counsel the patient that this is a risk factor for both adverse fetal and adverse maternal obstetrical outcomes. And as the age increases, the risk as well increases for both fetal anomalies and maternal complications.
Okay. So would you do anything special for this patient, given her age?
Sure, I would recommend prenatal genetic screening with non-invasive prenatal testing. I would also offer diagnostic testing with CVS or amniocentesis due to the increased risk of chromosomal abnormalities in patients who are over 35 years old. I would also recommend starting low-dose aspirin at 12 weeks for an increased risk of preeclampsia with patients who are over 40.
So, what are is age considered a high risk factor or a moderate risk factor?
I believe age over 40 is a high risk factor, but I could be wrong about that.
Okay. All right, so you're going to offer genetic testing, both screening as well as diagnostic. You mentioned the aspirin. What did I miss?
Aspirin, I would definitely recommend a 20-week detailed anatomy ultrasound. I recommend that for all patients, but especially in this situation.
Okay. Would you do any increased antenatal surveillance on the baby?
I would, in a patient who's over 40, I would start antenatal testing at 32 weeks due to the increased risk of stillbirth in patients who are over 40.
What about timing of delivery?
I would deliver these patients between 39 and 6. Again, due to the increased risk of stillbirth.
Okay. And you mentioned NSTs at 32 weeks. So would you do them weekly, or what would be your criteria there?
I would typically do weekly.
Okay. All right. Very good. Thank you. So let's go over this one. So I thought you did a nice job there. So, they are patients that are AMA are obviously at increased risk for chromosomal problems, and you described all that. Patients that are AMA, and I didn't actually ask you, but are also at increased risk for hypertension, diabetes, and basically all the complications that fall under those
Right.
conditions. So large for gestational age, small for gestational age or fetal growth restriction, FDIU, C-section, would be just preeclampsia, of course, just to name a few, increased risk of stillbirth, as you mentioned also. So patients that are AMA, it is recommended to do even a first trimester ultrasound because of the increased risk of multiple gestation. And part of that's going to be due to the fact that statistically, these folks are going to be at higher risk for having had ovulation induction.
Okay.
And also, of course, there are increased risk for congenital anomalies. So, of course, dating is important, as well as, looking for any evidence of any congenital thing, particularly nuchal translucency, perhaps in the first trimester. But again, they could have had ovulation induction or assisted reproductive technology. So that would be something to consider. Your aspirin point, so over age 35 is a moderate risk factor. To my knowledge, they don't distinguish 35 versus 40 in this case. So she would need another risk factor, if you will, to receive aspirin.
Okay.
If she's going to be age 40 or more at delivery, it is recommended also to say it again.
I mean, in this patient, nulliparity, I guess, would be another risk factor, so that I would give her aspirin.
Yep, fair enough. that would work in this specific patient.
Yeah.
Let's see. If they're going to be over 40 at the time of delivery, a third trimester growth scan is recommended because, again, as we just mentioned, these patients would be at increased risk of having a baby who's large for gestational age, or one who's small for gestational age, or obviously growth restricted would, of course, be an increased risk. Your testing at 32 weeks is good. So anywhere between 32 and 36 weeks, according to ACOG, you'd start the antenatal testing. Anywhere in there is acceptable. And you correctly told me that you would deliver between 39 and 39 and 6. We don't want to let these folks go past their due date. A 40-year-old at 39 weeks has the same risk as a 25 to 29-year-old at 41 weeks. So we normally would try to deliver that 25 to 29-year-old roughly 41 in a day. Not saying you couldn't let her go to 42 weeks, but that's the risk equivalent of this 40-plus-year-old at 39 weeks. And we're saying we'd let her go that extra week. So you're really starting to get on thin ice, going beyond her due date. So that would be the recommendation. And this actually came out, these recommendations were in an ACOG publication from August of 2022. So if you have any questions, certainly feel free to refer to that. Okay, thank you very much, Lauren. Appreciate you volunteering. All right, so let's get to the questions, guys. Give me just a second. I'm gonna pop them out here. Okay, first question, can you repeat the indications for vaginal progesterone? Yes. So again, of any patient that would be a candidate previously for McKenna or IM progesterone could be offered vaginal progesterone. So first of all, anybody that has a preterm delivery that's non-iatrogenic before 36 and 6 could receive either IM progesterone or vaginal progesterone. Now, I know IM progesterone, there's talk by the FDA of actually removing the IM progesterone. ACOG, to my knowledge, has not changed their, it's not that they're recommending it. They say you can offer it to a patient. They also say you can offer them either form of progesterone supplementation if they are a candidate for progesterone. So again, the preterm delivery less than 36 and 6. Now, vaginal progesterone specifically, though, should be offered to somebody who is incidentally found to have a cervical length less than 25 millimeters on a routine, let's say, second trimester scan. So less than 25 millimeters, again, she would be a candidate for vaginal progesterone. And that's without any history of anything else. Okay, so let's see. No hard fast rule. No hard fast rule. Concern would be for rupturing membranes. If a patient is very dilated, 3 to 4 centimeters, can place a Foley catheter to push membranes up and then perform a cerclage. Also concern for, I'm not sure what that looks like, 3. So in patients that are dilated on physical exam, cerclage in general, consider pre-op amnio and gram stain to rule out infection. So this is a patient who's got bulging membranes or has exposed membranes because of more moderate to advanced dilatation who has not delivered. So Janelle, if I misstated anything, please feel free to let us know. So Brittany, thank you for checking the ACOG publication. To practice bulletin 142 on cerclage, and it doesn't specify an exact amount of dilation for exam indicated cerclage. So that's kind of what I was trying to say. I haven't been able to find anything, but again, in talking to some MFMs and what have you, the general gestalt that I've gotten is 1 to 2 centimeters. Again, that please, feel free to use it in terms of your choice, but I would state, that there's no specific dilation that you're aware of, unless, again, something that we don't. So thank you for those that put comments in the question or chat. I'm going to put everybody's hand down in 1 second, and then I'm going to see if anyone has any comments or questions. I'm happy to take them off mute. Give me 1 second, guys. All right, everybody's hand is down now. So if anybody wants to say something, either ask a question or make a comment, please raise your hand. I will take you off mute. Going once, going twice. Okay. Guys, reminding you about the Finishing Touches course, and I will look forward to hosting actually your last webinar, which will be a week from tomorrow. And of course, it will be a structured case one, and that's the last one for November, because you guys take the test the following week. So I wish everyone a happy, healthy, and safe Thanksgiving. And I will look forward to speaking with you guys next week. In the interim, there will be other folks conducting the webinars. Thank you for your attention and for dialing in, and I hope everyone, again, has a wonderful holiday. Good night.